Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us for our program, Antimicrobial Stewardship, Its Significance and Impact. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credit has been approved for nurses for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year, expiring on July 31st, 2017. I'm Marilyn Knight, nurse educator with Clinical Management and Practice at the Alabama Department of Public Health, and joining me today is Dr. Albert White, infectious disease physician and Area 3 health officer at ADPH. Welcome, Dr. White, and let's get started.
Thank you, Marilyn, for inviting me to participate in this program today. As Marilyn said, our topic for discussion today would be antimicrobial stewardship, its significance and impact. First of all, I'd like to go over what I hope to achieve today with our objectives. We're going to have an introduction of antibiotic stewardship, and you will see that I will be using the word antibiotic and antimicrobial interchangeably, but I think antimicrobial is probably more relevant. We will discuss the mandate from CMS for healthcare facilities, and most recently the Joint Commission has also weighed in at what is expected of healthcare facilities. We'll also discuss some activities that are associated with antibiotic stewardship and how to accomplish this. And finally, we will talk about some of the benefits of the antimicrobial stewardship program, and I will be sharing with you some of the data from the hospital that I currently work at in Tuscaloosa, Alabama. Starting in the early 2000s, we began to see and hear a lot about antimicrobial stewardship. And there were lots of papers put out there to show that this was important, as we were finding a lot of problems with people overusing antibiotics, and people having complications associated with antibiotic therapy, that several major organizations in the medical profession, including the Society for Hospital Epidemiology, the Adult Infectious Disease Society of America, the Pediatric Infectious Disease Society of America, all came together and put out a policy statement in 2012 talking about antimicrobial stewardship. Also in that same article, we saw collaborative partnership for antimicrobial stewardship. What were all the organizations that and groups of people that needed to be involved in an antimicrobial stewardship program? In 2016, the IDSA and SHEA, they updated their consensus guidelines as to what implementing an antimicrobial stewardship program entails. And these guidelines were put out there by the IDSA and the SHEA. They were participating together, and those guidelines you can find in 2016 May edition of CID, that's the Clinical Infectious Disease Journal. Most recently, in June of 2016, we had a publication released from the Joint Commission for Hospital Accreditation, and this agency is the main agency that accredits hospitals and healthcare institutions around the country. And the Joint Commission has now announced that antimicrobial stewardship is important, and this is something that they will be grading these institutions on. What their standards are and what are to be expected was released in this document here that I'm showing that came out on June 22nd, and it will be effective January 1st, 2017, meaning that they will expect hospitals and healthcare facilities, whether inpatient or outpatient or long-term care, what all the standards for antimicrobial stewardship should be. So it is very pertinent that all these institutions get on the bandwagon and begin their program if they have not started one already. So what is antimicrobial stewardship? It's a broad definition. It includes any activity which will improve the use of antimicrobial. And I say antimicrobial because it's not only antibiotics, we're also talking about antifungals, we're talking about antiparasitic agents, antivirals, any of those activities that can improve and streamline the use of these agents. It also helps us to select antibiotic appropriately, to give the correct dosing, the correct route of administration, and the correct duration of therapy. Antimicrobial stewardship goals include several things. We first want to optimize the clinical outcomes of the individuals. You don't want to have your patients there where you're just giving them antibiotics and eventually the antibiotics end up hurting the patients because it's either given too long, it's the wrong one, it's not at the right dose of anything, and that can cause problem. We want to minimize the unintended impact of antimicrobial use. And of course, we all know that if you use antimicrobials all the time, especially broad-spectrum antibiotics, you are going to have the development of resistance of the organisms that have been exposed. So we want to slow the development of resistance in these organisms. We want to minimize the selection of pathogenic organisms. And this is something that happens. Maybe people do not know that when you kill a lot of organisms in a person's flora that sometimes challenge pathogenic organisms, those organisms will die out, and the pathogenic or resistant organisms will persist. They will grow, and they can overcome your system. We want to also minimize toxicity when we do our antibiotics, antimicrobial stewardship. And what I call a secondary goal is decrease in healthcare costs. Sometimes people think that antimicrobial people in the hospital, your pharmacists and your doctors, they're telling you, not to use this or so because they want to decrease their costs. But no, our primary aim is better patient outcome, and eventually it will show in your costs being minimized. So what are some of the things that are needed for a successful antimicrobial stewardship program? In any institution that you institute this service, the institution philosophy has to support the program. You have to have the commitment of the leadership of the institution so that they can help your program work. Many times, some of the basic fundamental things that you need in your microbiology lab or in your pharmacy, if it's not there and the institution and leadership is not willing to provide those services, those instruments or whatever that's needed, the program will not succeed. You also have to have the infrastructure that can support an antibiotic stewardship program. What are some of the key elements of the antibiotic stewardship program or antimicrobial stewardship program? You have to have a physician and a pharmacist. And many of the papers that I see, they would make a distinction that they want an infectious disease physician. That is not a luxury that many facilities have, to have an infectious disease physician on staff or is available. But a physician who has interest, like a primary care physician, an internal medicine physician, or even a surgeon or so, or a pathologist who has interest in that, they can be on board. And of course, you need a pharmacist. I don't think any stewardship program can work effectively if you don't have great pharmacy support. You also need a microbiology lab, a lab that will be able to give you data about what organisms are being isolated in your facility. We give you the sensitivity data. You need for them to have some baseline data, compare it to what's coming on later on, and all of that. A P&T committee, a pharmacy and therapeutics committee. It is very important too that the pharmacy and therapeutics committee be involved in your stewardship program, because some of the things that a stewardship program needs to enact needs to go through the P&T program, where which consists of medical staff, personnel, and other key individuals, to pass some rules and regulations regarding your facility. Medical leadership, I mentioned that. I cannot overemphasize that it is so important that the medical leadership be involved. Infection preventionists, these are your infection control nurses, your infection control practitioners. It is very important for them to be involved in the stewardship program, because they can alert you to some of the things that are happening, and especially when you are dealing with things like C. difficile colitis and outbreaks of these are things that the stewardship program and the IP people need to be involved in helping to prevent that, and we can be having strategies to recommend to your medical practitioners how to treat C. difficile if it occurs, and how to use the antibiotics that will be less likely to cause C. difficile colitis. Your IT department is very important, that your information technology department be available to help the stewardship program. They will be the ones who will help you when you make your prompts to find out, okay, I want to know how many MRSA cases we've had in the TSICU within the last month. Your IT folks can set up that program that you can have it. Or you can ask them to print out to your office every day any organism that is resistant to vancomycin or something like that, and then you can get that printed out. So it's very important for IT to be on board to how to interact, to use the microbiology data and your antibiotic sensitivities to help you, the practitioners, get that information. And this information should not be available only to the ASP team, not only to the physician or the pharmacist. All the practitioners in the hospital should have access to this information through IT. Continue on the infrastructure of ASP, we again need to identify that ASP physician or infectious disease preferably, or anyone else who has interest, and the pharmacist champion. We have to engage these leaders and members to support the team and be advocating for resources that we need. You also need to conduct a baseline facility assessment to find out what your facility has, what the facility is going to need, based on the recommendations from the IDSA that came, the guidelines that they've put out there about what you need to start a program. Then you use the information that you collect to develop your ASP goals and your strategies. Now, many times there are in some hospitals that facilities that do not have a formal ASP program, but everybody does have a P&T program. Some of these ASP maneuvers are already in progress. They're ongoing in your facility. So, and some of them you have made some progress in, but others you may not know them until you have really collected the baseline data and see how to organize your program and your strategies. Be able to communicate the goals and strategies to key stakeholders and give feedback to the staff regularly. This is very important. Again, when you have the information that you have that you're collecting over a period of time periodically, you need to share that with your infection control committee. You need to share that with your P&T. You need to share that with your hospital administration, and also to the staff, the units on the floor. You need to let them know, for instance, if you're finding a particular problem on a particular floor or so, and you've made some strategies and they have improved, you need to let that information get back to your staff on a regular basis so they can know that you all are doing what you plan to do. What are some of the ASP Core Strategies? We have to, again, review your pharmacy formulary and contracts annually. This is something that, again, every pharmacy needs to look at, because sometimes you have agents that are duplicate, or agents whose costs are going up, but you need to adjust it and review them annually so that they can be current of what you have going. Identify costs associated with each antimicrobial. Again, sometimes people do not know, physicians or prescribers do not know the cost of agents that they're using. It's sometimes just because you've had a drug rep or someone who's come into the place and he told you about this new drug and all of that, and you want to use the drug, but you may have another drug that may be just as effective, but it will be a fraction of the cost. So we need to identify the cost and let the physicians know. Sometimes when we have an agent that we are monitoring closely and a doctor has ordered it, and I end up calling the doctor and say, well, based on the sensitivities and stuff that we have, this other agent would be just as effective. Can we use that? And tell them, do you know what the cost for that agent per day would be? And they were like, wow, I did not know that. And sometimes when you do order an agent and you give a patient a prescription and you don't know what the cost of the drug is, that patient goes to the pharmacy and the patient will not fill in the drug because this cost was too exorbitant for them. So that's an area we need to do a little bit more of, letting the providers and people know what the cost is. Assess for duplicative agents and develop process to remove or streamline. This is something, again, that a lot of facilities have done over the years, that you don't have to have several of the same class of an agent on your pharmacy. And we've done that especially with the quinolones over the years. As the quinolones come up, you know, a lot of them are given on a daily basis. They have a similar spectrum or so, but then their cost may vary, and, you know, some of them have a little bit more side effects than the others, but you need to have your P&T team evaluate the drugs and see which one you say, okay, this is what I would go with, and you sort of do what they call therapeutic substitution. That means if somebody orders that particular drug, all you do is give the therapeutic substitution that has been approved by the P&T committee, and that there will be no adverse effect to the patient. They will be getting the appropriate class of drug. You also need to define criteria for the use of certain agents. And I put the word restricted in parentheses because that is a word that not many clinicians like to know that, this drug is restricted and I can't use it. I have a license to order drugs, and how come you're telling me that, you know, it's restricted? And to tell you the truth, to monitor restricted drugs in a facility, it takes time. I mean, you have to, you know, have a team. Only those hospitals that have, say, an ID program for training, or so that can have fellows and residents on call, you know, to monitor that restricted list or so, because at, you know, 6 o'clock in the morning or 3 a.m. or so, if a drug is ordered, you don't want to be, you know, calling people to come and review it if the patient needs it. So you have to have certain criteria. Many times the drug would be dispensed, and then it will be reviewed subsequently. At our facility, we don't have any drugs that are restricted, or we just monitor the use, and we talk to the individuals on a one-to-one basis to, you know, to see if we could do something else. We also need to be sure that the agents available for formulary align with your antimicrobial susceptibility testing from the micro lab. There's no point having your micro lab put up susceptibility testing for an organism that has been isolated in the blood or the spinal fluid or so, and they tell you, oh, it's sensitive to this drug and that drug and the other drug, but those drugs are not available on your formulary. So it's good for you to coordinate with the micro lab and say, okay, these are the drugs that we have on formulary. Let's have a panel that will give us sensitivities to these agents so that it can be aligned. So that's something we have to work on in our facility also. Continuing on strategies, you need to let the folks know how to order an agent that you are monitoring or that's restricted, and let them know, that maybe it will be given for 24 hours, but then it will be reviewed, and let them be aware that you may be coming back to them. Many times, the restricted agent is appropriate, and, we'll let it be used, but many times we have to come back and discuss it. A process to communicate and reinforce the formulary. That, again, is something that the P&T committee is very involved in. As we move medications off or bring some on the formulary, we need to let the medical staff know about that so that they can know that, well, this drug is not available, either because of manufacturing issues or adverse effect, and it's been pulled from the market or something like that. You need to have a process to audit the use of certain agents, and again, a process to review contracts to reduce costs. Auditing the drugs is something that we do. We call them MUEs. Sometimes we have a pharmacy resident or someone look at a certain drug, say, clindamycin, meropenem, or whatever, over a 3-month period, and see what instances it was used, or was it appropriate, was it inappropriate, and use that as the results from that as a method to teach and inform your staff about what is happening. Communicate comparative antibiotic cost per day information. That's something, again, we talk about. Determining what the cost per day for each antibiotic. We need to have that information and put it in a graph form and have that available at your P&T meetings. Put the chart in your doctor's lounge or something for them to see and know what those costs are. Develop drug utilization evaluation. That's DUE I was talking about periodically. We do that, and that's part of what a stewardship program should do. Let the people know how the drug is being used, whether it's appropriate or not. And these utilization reviews does not go only for antimicrobial agents. They can be done for any agent in your facility. Develop a process to communicate specific, patient-specific ASP team recommendation to prescriber. This is one thing that I have done a lot, and sometimes I look forward to doing, because sometimes when you have a one-on-one interaction with a physician, or with a member of a team, say like a team of the hospitalists in your group. If you saw there was a pattern with those physicians in the prescribing, you meet with one of their leaders or so, and you tell them or show them, why it is not good to say be double coverage for anaerobic bacteria, something, and explain the need why that doesn't need to happen, and then that will go on to the rest of the team. And if they work at another facility, they will carry that information that they learned to the other facility and make the appropriate adjustment in their practice. The ASP program also needs to track adherence of the team recommendations for patient-specific antibiotic treatment. And I will share with you a slide when we talk about what we've done at our facility, about how many recommendations we make per month or so, and what is the acceptance rate among your staff. I mean, if you're making recommendations that they don't trust and they don't do it, then you don't have a good program. And I can say we have over 90% acceptance rate of our recommendations for patient-specific antibiotic management at our hospital in Tuscaloosa. We need to also monitor resistance to the agents at your facility. This is, again, is where the microbiology lab is going to be helpful, because when they do the culture and the sensitivities, over time you can see what those sensitivities and resistance is, and create your antibiogram, which again is our next thing. Utilize an antibiogram that is facility or unit specific if possible, and share that information and update with your prescribers. We have an antibiogram that we create every quarter at our facility, and we post that in the hospital. We put it on the online so that every practitioner, every nurse, everybody can have access to it. And for us, that antibiogram, it represents the whole community, because DCH Hospital is the hospital that does a lot of lab work for outpatients and everywhere around there. So anytime we isolate a particular organism that we're monitoring, it doesn't only come from our inpatient setting, but also from our outpatient. And another thing that we can do is that we can look at a particular unit, say the MICU, and just look at all the organisms that come from that unit, and look at their sensitivity pattern and have an antibiogram for the ICU or the TSICU. So that is a very good thing, strategy to have. There are many more strategies that exist, again, depending on what resources you have, what your medical leadership and your CEOs and other in the hospital have been helpful to you to get. But some of the basic things that you need to do, if there are opportunities for you to do them, you need to start doing them now. Now, as I mentioned, I work at DCH Hospital in Tuscaloosa, Alabama. That's our hospital in the background, and we serve 10 counties or more around there. We have a smaller hospital called Northwood Hospital across the river, and together, both of them, I think we have inpatient capacity of over 700 patients, and it does a lot of good things for our community. We started our program at DCH before those 2012 consensus statements and guidelines that came up from IDSA. I had attended a conference in Atlanta of the Society for Hospital Epidemiology, and there were a lot of papers done then about ASPs. And when I came back to the hospital, I met with the leadership team, and we had a pharmacist there, Dr. Stephen Urey, who had some special training in infectious diseases, and they approved for us to start a stewardship program, and that's when we did that in late December, early January of 2009. So I've led that effort along with Stephen Urey, our clinical pharmacist. We also have support by 2 additional clinical pharmacists who incorporate ASP activities in their daily rounds in the areas in which they are assigned, especially our intensive care units. We have additional support from pharmacy residents. Well, the DCH has 4 pharmacy residents per year, and many times 1 or 2 is assigned to the stewardship program, and they help us to collect data and take out our recommendations to the staff. We also have a multidisciplinary team that's involved, including our microbiologists from the micro lab. We have all the infection control nurses, Beth Goodall and her team, who help us. We have the IT division that help us to get all the reports and stuff that we want on a very instant basis. We also have the administrative support from our CEO, Brian Kindred, our administrator, Bill Castle, Luke Standifer from Northport Hospital, Dr. David Rice, who is retired now, and Dr. Ken Aldridge, who is currently one of the CMOs at the hospital. These individuals have been very instrumental in helping us get the team going. We do give semi-annual reports to the P&T committee and the infection prevention team. Our pharmacist, Stephen, is a standing member of the P&T and the infection control committees, and we are there for all the meetings, and if there's some stewardship program issue that comes up, we're able to address them. ASP activities started at DCH prior to our development of our program in 2009, and some of those things that were done and approved by the P&T committee were pharmacists run programs which included the IV to PO conversion. That is something that is simple, and we can, if hospitals have not done that, that's something that they can do. And some of the drugs that are easily used in an IV to PO combination or anti-infectives would be things like a quinolone, like levofloxacin or so. We will automatically, after 48 hours of IV levoquin, we'll switch it to PO if the patient is able to tolerate PO. And if he's taking other PO medications, there are no contraindications, no NG tube, he's not like a post-gastric problem or something and, getting suction, we will do that automatically. We don't have to have an order to do so. Fluconazole is another agent that we can do because the bioavailability and absorption of those agents are very easy and they have a good, absorption and being available, we can do that. So not only antimicrobials, but there are other agents that we can do automatic IV to PO, and you can see we do more than 1,400 of those per year. Of course, the cost for PO is much less than IV, but we do not compromise the patient care by doing that. We also have automatic consults to the pharmacist to look at pharmacokinetics with agents like vancomycin and aminoglycoside. They do that automatically. Anytime it is ordered, they will look at the patient's renal function, they look at their weight, they will look at prior exposure, allergies, and all of those things, and decide, like if a doctor write a dose for, say, 300 milligrams of tobramycin or so, and the patient has bad renal function or so, the pharmacist will make the appropriate adjustment, and so that the patient, we won't have to wait like 3 days before you find out, oh, this is what's happening. They do that automatically. And that's something that if you're not doing that in your facility, you need to consider doing that too. We have automatic renal dosing program too, where more than 5,000 doses adjustment per year is made for drugs according to their renal function. Not only the aminoglycosides, not only the vancomycins, but also cephalosporins and other drugs that have to be adjusted because of patients' renal insufficiency. So those things were done preceding our ASP program. So when we started the program in, again, 2009, some of our early goals were decreasing the unnecessary double coverage of anaerobic bacteria. I had mentioned that earlier. There are lots of times where we found that patients would be on a drug like Zosyn, which is piperacillin tazobactam, plus Flagyl for whatever reasons. If they're treating especially intra-abdominal problems, abscesses, diverticular abscesses, and peritonitis, and all of those things, yes, you want Zosyn to be on board, which has excellent gram-negative coverage, but Zosyn also has anaerobic coverage. So there's no need for a patient to be on Zosyn and Flagyl. And we're finding that, Timentin and Flagyl, or imipenem and Flagyl, meropenem and Flagyl, drugs that have anaerobic coverage, you do not need to add Flagyl. Now, there's certain times if you're treating C. diff or something like that, that is may be different. So we try to get that information across so that we will avoid the double coverage. Sometimes they have double coverage for another gram-negative infection. They're on cefepime and rocephin. You don't need to have those two drugs on together. So we'll find that out, and we'll let the doctors know and make our recommendations, and many times they will do so. Duration of antibiotic therapy. Again, that is a big thing. Now they're talking about antibiotic timeout, where after 48 hours or so, you need to reassess your broad-spectrum antibiotics and decide, does that patient need it? Is this patient rarely septic? And because that's a big thing now about sepsis, and we're trying to recognize it early and having antibiotics on board. But after a 48-hour period, you need to stop and reassess And also we are trying to get people to write a duration of antibiotic. If you're treating the patient for a pneumonia or for cellulitis, when you write the antibiotic the first time, say, do it for 7 days, do it for 8 days, do it for 5 days, whatever you're treating, rather than just put it on board and then leave it. And sometimes if nobody is watching, the patient would be on ceftriaxone for 23 days, and you're trying to treat a urinary tract infection that could have been treated in 5 or 7 days. So the PNT, or not the PNT, but the ASP program is monitoring that, where we're looking at duration. And there are certain things, and then that's when you have to go in the chart and look at what are they treating. Yeah, if they're treating meningitis, okay, yes, meningitis has to be treated for a longer time than 7 days, then we don't bother. If you're treating osteomyelitis, then yes, they need to have it more than 23 days or so. But we have to go into the record and look at that. We also, again, want to encourage timely narrowing of antimicrobial therapy based on microbiology results and the patient's response. So the rule of thumb is to start broadly, vancomycin, Zosyn, meropenem, or whatever. If the patient is sick, the patient is septic, you don't know. But then after you have your reports come back where your blood culture is positive for E. coli, and you look on your sensitivity pattern, you see that E. coli is sensitive to ceftriaxone, or is sensitive to sulfasaline, or to amoxicillin, or to ampicillin, then there's no need to have vancomycin on board. There's no need to have that third-generation cephalosporin on board again. You can back off and come to an appropriate narrow-spectrum organism, probably a narrow-spectrum antibiotic agent, and an agent that will have less toxicity, that will be more effective, used in fewer dosing, and all those are some of the mantra, the ID docs, that we look for when we try to select an agent for a particular organism. Encourage timely narrowing of the antibiotic. We again try to reserve the newer generation antimicrobial for known or highly suspected drug-resistant pathogens, and this is where we initially had a lot of concern and pushbacks, and because everybody was used to jumping on the new drug on the market, and the drug reps were really aggressive about pushing these drugs. But sometimes when you come to think about it, and I don't want to be calling any drug names before some of these people think I don't like the drug or anything, but some of these agents, they're very costly. Causing thousands of dollars or hundreds of dollars per day, compared to an agent that costs you $7 or $10 a day that will do the same thing. Again, it's not that you're trying to be cheap on the patient or trying to deny them of getting certain things. So that's why we have streamlined how we entertain drug reps in our facility, and what they have to go through. And we let them give us the data, and then we decide where is that drug going to fall in our armamentarium, because many times we already have a class or an agent in that class of drug or so. Now sometimes if it's a new class of drug or so, fine, we can bring in that drug, because if the patient has allergy to penicillin, to cephalosporins or so, yeah, then we may want to use a different class, and then that we say yes, that would be okay. Or if the patient has sensitivity patterns that is being resistant to all these other drugs, then yes, you can go on to use the newer generation agents. But we do have a way in which we're not restricting it, it's available, but we just monitor the use. We do have education that occur, again, on a one-on-one basis with physician or provider specific, where we communicate with them in the form of the chart, or we do verbal communications with those individuals. Early on, I had to do a lot of verbal communications with providers. We call them, we talk to them, we bring the data and show them why we recommend this or recommend that or so. And I in my experience, found that to be very helpful. I mean, it was non-confrontational, and I think it helped all of us, grow together as we have a means by which we can communicate where a new agent would fall into our armamentarium. So we do that on a regular basis, and sometimes if we find a particular physician, doing the same thing over and over, then yes, I will call him and we'll talk to him, and we'll invite him to our infection control meeting or invite him to our stewardship meeting and let him, tell us why he wants to do this, and we usually have an amicable solution to these things. But I call it education. Evaluation of combination therapy will occur on a daily basis. This is some of the things that we did. Every day we wanted to make sure that one of the things we said, okay, anybody on 3 or more antibiotics, the stewardship, we're going to review it, because it's not very often that a patient is going to need 3 or more anti-infective agents. I mean, because it's just not needed. So sometimes if we saw that, we will review them, and many times we'll find out that, the things could be narrowed. We could probably get rid of 1 or 2 and come down, or increase the spectrum of one of the agents, to cover the 2 agents that one person was trying to use 2 drugs to cover 2 different bugs. We have 1 drug that could cover those 2, and we do that. So it comes up every time, and I think the physicians in our facility will get to know that, yes, if your patient is on 3 or more, you either need to call for a consult, or you're going to get a call from the stewardship team. And when appropriate, we recommend, simplification of the dosing, or sometimes, again, we recommend dose optimization, because sometimes they will be on a drug and they're giving them, 100 milligrams daily, and this person requires 400 milligrams daily. And that makes special reference to the treatment of candidemia. This is Candida in the bloodstream. If Candida in the bloodstream is someone who has a central line or has a Grosjean catheter or something, that line needs to come out. That's one thing that sometimes they will just put the patient on the antifungal and don't, realize that the line needs to go. And if they're on 100, they're used to treating urinary tract infection with 100 milligrams. Well, a bacteremia, you need 400 milligrams. And now if the patient has renal failure or on dialysis, then that 400 milligrams need to be adjusted because of the renal insufficiency, and that's where the pharmacist will come in and make that appropriate adjustment. So we don't only say to stop medicines, but we want to optimize the dosing when it's appropriate. Streamlining or de-escalating therapy will be recommended when appropriate, and I think that's one of the things we do most often: streamline, recommending de-escalation. Dose optimization when appropriate, I think I've talked about that already. Increase or decrease in the daily dose. We target certain antimicrobials because of their costs, and again, we want to prevent them from having adverse events, and we know about the rise of C. difficile and all of that, and we try to, there are some institutions that there are certain drugs that are known to be prone, to develop, people to develop C. diff, and they just took it off the formulary. They just don't use it. Or before you use it, you have to have an ID consult all the time. Well, we don't have that luxury. Many places don't have that luxury, but people need to know about some of those agents and, how to use them in a cost-effective and less incidents for complications. Alternatives which are more cost-effective and carry less risk of adverse reactions may be recommended, and that's part of what we do. This is the form that we use. It doesn't really, it's usually on an 8.5 by 11 sheet of paper. We had to modify it to fit the screen here. But this is the form that the stewardship team will use. We put the patient's name, the room number, the date that we're doing that, and we put what the indication for the antimicrobial therapy is. So we look through the chart, and we find out they're treating a meningitis, they're treating a pneumonia, they're treating a UTI. We find the organism from the microbiology data, and we check it to see, okay, does this organism, is the drug that they're on, is it sensitive to this organism? If we find that, we see. But if we find out that, the patient has E. coli in the urine and in the blood, and the patient is on Levaquin, but the E. coli is resistant to Levaquin, well, we want to know that day. We don't want to wait 3 days to find out the patient be in the hospital 3 days and getting the wrong drug. So if we find that, we will let the doctor know, say, hey, please and then we'll check the box that says antimicrobial optimization based on microbiology and clinical, syndrome. We check that box and say, and make a recommendation and say, please change to this, or, these other agents are more effective. If they have duplication of coverage, we'll tell them, the duplicate coverage, please consider stopping one, and we'll make a recommendation about which one to stop. We talk about de-escalation. Sometimes we make a recommendation regarding duration of therapy. We come to find out the patient had a UTI, they've been on antibiotics for 12 days, they have no fever, they have no leukocytosis, they're walking around the floor. We'd be telling them, hey, please consider stopping that regimen. Now, we don't have the authority to stop the antibiotic on the patient. They're not in our care, and so we don't do that. But many times, as an infectious disease consultant in our hospital, I may be on the case, and it really many times I'm disappointed if my stewardship team has to call my attention to a regimen that my patient is on that maybe I haven't done the appropriate adjustment. And so we always have a joke about that. It was Dr. White, you know, one of your patients. I said, oh, let's do that. But I don't want to make light of it, but that's, you know, sometimes that's my goal is I don't want my stewardship team to be calling me out. I like to do things because that's what we're asking everyone else to do. But so when we put this in the chart, the doctors will see it, and if they make a adjustment or so, we will mark that as, okay, this is an intervention, that intervention was accepted. Sometimes the doctor will put right on that thing about why they want to continue what they're doing, and, you know, and all of that, and we just take note that, well, that recommendation was not approved. Now, what I will share with you now is some of our reports for some of the that we have accumulated over the past years. I think many of these slides go back to 2011 and up to fourth quarter 2015 at what are some of the sensitivity data and stuff that we've had on our antimicrobials. This slide has allowed the intracellular agents, which include the aminoglycosides, as amikacin. We have the clindamycin, we have Tobra, we have azithromycin, the macrolide, and metronidazole. So if you look at the slide, you see the big arrow on the far right tells you that if the use, this is looking at the use of the antibiotics now. We'll have another slide for what the resistance has shown. But if the use is coming down, that's good. That means that when they're not being overused, especially with the aminoglycosides, they have a lot of renal toxicity and stuff. We don't like to use that. Clindamycin is associated with, you know, C. difficile colitis, but there are certain times that it is useful. We need to do it. And you can see Flagyl. The Flagyl is the purple line there. It has remained flat, you know, going because it's a sort of a workhorse for anaerobic infections, especially in the intra-abdominal cavity or below the diaphragm. Azithromycin use is there too. It's a common agent used in community-acquired pneumonia, but we also see that their use is going down. So down is good for these things. On the x-axis is time, and on the y-axis we have days of therapy per 100,000 patients, and you can see those are, you know, 0, 10, 20, 30 or so. So we like to see those numbers go down. Cell wall antimicrobials, these are, again, your beta-lactam drugs like the carbapenems and the cephalosporins, ceftriaxone, rocephin, meropenem, zosyn, and cefepime. Again, we like to see those numbers go down. Those are our big guns, our broad-spectrum agents for gram-negative organisms. And we can see the line for zosyn has been, you know, dipped down, and then it went back up. Sometimes we have shortages in those. I mean, we can't find them. But again, those numbers, we really would like to see them go down. The newer generation MRSA antimicrobials, again, those are some of the newer generation agents that compete with vancomycin. Vancomycin will fall in this category here, and you see there's ceftaroline, there's daptomycin, which is cubicin, there's linezolid, which is Zyvox, and tigecycline, which is Tigecyl. All of those agents they use have been going down when we look back from 2011 with Tigecyl in the red. That has come down, you know, very low number of days of therapy per 1,000 days. And we can see that linezolid, which is the green line, that line seems more stable or on the rise. And there are several reasons for that. Is that now that drug has gone generic, so it's a cheaper form. The oral form is cheaper now, so that we can use that instead of vancomycin, which has been our bread and butter antimicrobial MRSA agent. These are agents that we use for Pseudomonas, and now this is not the y-axis here does not include the days of therapy, but the sensitivity to Pseudomonas. Pseudomonas is a gram-negative organism that everybody fear. It can cause, you know, significant infections, especially in patients with aspiration pneumonia, hospital-acquired pneumonia, cystic fibrosis, and we have to have something that it's sensitive to. And if you look at the third and fourth generation cephalosporins, that's cefepime, ceftazidime. We also have the quinidone, levofloxacin there, Tobra, Zosyn, and the carbapenem, meropenem. All of them, if you look in 2011, they were all some of them were in the 70s and 80s range or so, but coming down to 2015, we see that those sensitivities are going up. And if you look at levofloxacin, I've been very pleased with levofloxacin's sensitivity to Pseudomonas over the years, moving from low 70s now into the high 70s, almost getting to the 80% of those organisms being susceptible to levofloxacin. So, I mean, we like that. We look at this and feel that there's been a change in our resistance pattern, especially for this organism, in a positive way. This slide is an antibiogram that we have from our hospital. This is the most recent antibiogram that goes through the fourth quarter of 2015. And I think it's included in the handout. It's, it's very small on the screen here for you to see. But what that shows, we call it our community antibiogram because it reflects what's in the community over this period of time. And on the top sets of numbers there, you have the gram-negative organisms, which include E. coli, Klebsiella, Proteus, and Pseudomonas aeruginosa on the far right. That's in the top. And the agents to the left side are the agents, the common agents that we have on our formulary to treat these organisms. And on the first column of each of those organisms, we have the sensitivity for calendar year 2014, and then we have the sensitivity for the fourth quarter of 2015. And in many of those situations, we saw that the sensitivities improve over the years. And as I mentioned about Pseudomonas aeruginosa, when we look at levofloxacin, which is the third from the bottom, we see that in 2014, it was 73%, and now in 2015, fourth quarter, it's 87% of our Pseudomonas were sensitive to levofloxacin. That is remarkable, and I think it's due to some of the things that we have done over the years. Looking at E. coli also, E. coli, the sensitivity for levofloxacin went from 70 to 71, so that's sort of stable. But for ceftriaxone, which is Rocephin, we see it went from 92 to 93%, and the rest of them are staying up in the 90 range. The lower sets of column and rows include our gram-positive organisms, and we have Staph aureus, MRSA, Enterococcus species, and VRE, which is vancomycin-resistant Enterococcus. And again, the agents on the left side are what we use to treat them. And we can see that for MRSA, if you look at the last line, which is vancomycin, we saw that for the whole year, 2014, 100% of all the MRSAs were susceptible to vancomycin, and similarly so in 2014. We have not had any MRSA organism resistant to vancomycin in our facility. But when you look at VRE on the far end, which means vancomycin-resistant Enterococcus, certainly you see none of them sensitive to vancomycin, and that's where we use some of our newer agents, the linazolid, the Tigercils, etc. So this antibiogram is available every quarter in our facility, and we post it in the doctor's lounge. We have it online in our DCH intranet page. Everybody has access to it, and even in our other sister institutions and outpatient practices around, like the UMC, they use it a lot. The folks from Bryce Hospital use it too, and everybody, because that is our community antibiogram. So it's good for programs to have something like this that they can go by. This slide shows the number of ASP interventions we've had over the years, and starting in 2014, that's when you see the smaller bars on the top. That's when we extended our program to Northport Hospital, which is a smaller hospital, and those are the numbers of interventions that we've had at different facilities. So you see we average well over 200, 250 interventions per month at DCH Hospital, and somewhere around 50, 60 or so per month at Northport Hospital. And we do have a anywhere between north of 85–90% of our interventions are accepted, either through a telephone conversation or through the form that we put in the chart, or some of the groups. We have an email system in which we communicate with them, the hospitalist group, by email when we have a specific intervention that we are recommending. So we are following that, and we like what we see. Antimicrobial costs per adjusted inpatient day. And if you look at this slide, again, comes from 2010, and we're looking at all the antibiotic together, taken together, we're looking at their cost per day, and we started off looking at a $15 or so, per patient per day cost for antibiotics, and we see that over the years, these costs have been decreased. Northport Hospital, again, started 2012. They have the smaller amount that we see around $6, $5.75 per day. But it's good to see that these costs have been going down. But we don't expect that they're going to continue to go down, because there are other things that affect this, or that we are noticing now, that especially with generic drugs that are coming out there, and now new companies are acquiring those drugs, and they are increasing the price of those drugs, sometimes by over 100-fold. So that may begin to to dig inside some of the cost savings that we have experienced over the years. This again is a DCH antimicrobial purchasing trend through December of 2015. Again, this emphasizes what I've seen. They used to spend over, I think it's $7-point-something million there, and it's come down. And then you see in the last 2013-14, they're out of flattening up or even going up now. And this is again because of some of those things that I've talked about, the price of these drugs going up. But this is, again, that's why I call this a secondary benefit of the stewardship program, having a effect on the cost of your antimicrobials in your area. So that was my last slide. And again, to summarize, I think the antimicrobial stewardship is a very important issue for healthcare facilities, hospitals, long-term care facilities, nursing homes to be involved in. We are going to be mandated, starting January of 2017 by the Joint Commission, that you need to show them that you have an antibiotic stewardship program and what you're doing, to improve and to monitor the use of antibiotics and how to assess your program. I've talked to you about what a program's composition needs to be. You really need a physician champion and a pharmacist. That physician does not need to be an ID physician, but again, there are some situations where if a physician is not on your staff and somewhere else nearby or so, you could probably have an arrangement with that physician in order to help you with your stewardship program. You cannot do it without pharmacy. Your microbiology lab has to be involved in there. Your P&T committee has to be involved. Your IT folks have to be involved, because you need the data from them. You have to have the support of your administration and your leadership to give you the tools and things that you would need in order to get the program going. You need to have some baseline data about what you're starting off with, and a way in which to track how you improve over the years. I know we were looking at all the things that we have done at our place, and Stephen was trying to make sure, because we are expecting Joint Commission any moment. Of course, that doesn't go into effect until January, but again, we want to be proud to show them that we already have an antibiotic stewardship going on, and whatever we needed to show that we are on to do, we are making sure we're getting them the letters of support from whoever we need, telling who the other people are, who we share our data with, and all of that. So with that, I will stop, and if there are any questions, I will be happy to take questions.
Dr. White, I have a question. I don't have anything coming in, so we encourage people to call in or send us an email. But is there any penalty to the physician as far as payment from CMS if they don't take your recommendation for the antibiotics?
No, I don't think it goes that far. I mean, it may have an effect on the outcome, the clinical outcome of the patient. Maybe his patient may stay in the hospital a couple of days longer than the ordinary they will. And yes, they are getting data on physicians now, to show how well they take care of their patients, and that will impact their reimbursement. But I don't think it's going to be specifically at whether they took an antibiotic stewardship recommendation or not. I mean, to me, it's if you have somebody on your team or in your facility who has a little bit more expertise in a certain area than you, and they're giving you, basically a free consult, to say, based on the data that we see, it might be better if we do this. Now, if you have reasons that we don't know or that's not in the data to show that, oh, I have used that drug before and the patient is allergic, although I didn't put it, then that's something else. But yes, physicians are going to be scored, according to how the patient outcome, and those scores are going to be compared to their peers, and their reimbursement will be, whether they get a penalty or something, depending on if they're not up to speed, but not specifically for not taking a recommendation from the stewardship committee.
And more.
Well, if there are no further questions, I will turn the floor back over to my co-host here, Ms. Knight, who has some other information that she wants to share with us today.
Thank you, Dr. White. I found your information very interesting. Well, on today, what we want to do is we want to review infection control information. We want to just remind our staff that while we know OSHA guidelines and standard precautions, yearly we want to review that information to make sure we're not getting overly laxed or too comfortable and not continuing with the guidelines as they have been established by the CDC. So on today, what we want to do is we want to go over a few topics. We want to discuss them on today. We want to talk about hand hygiene, personal protective equipment, injection safety, environmental cleaning, medical equipment cleaning, and respiratory hygiene and cough etiquette. Okay, so on today, we are very familiar with hand hygiene, and we just want to remind our staff that the preferred method for hand hygiene is the use of alcohol-based hand rub, except when hands are visibly soiled. If hands are visibly soiled with dirt, blood, body fluids, or other substances, washing with soap and water is more effective. And we should have those alcohol-based hand rubs available throughout all of our facilities for our staff to have ready use when those are needed. Times to perform hand hygiene. Just want to remind you, before and after any type of physical contact with your patient, we need to perform hand hygiene, as well as any physical contact with blood, body fluid, or items that contain blood, body fluids, or other excretions from the patient. We want to perform hand hygiene before performing aseptic tasks and after gloves have been removed. That's very important. I know oftentimes in our duties, we're in a rush. We're trying to get the patient seen and everything done in the day. But we want to remind you, anytime you remove gloves, it's very important that you go ahead and perform hand hygiene at that point. Talking about personal protective equipment. Remember that your personal protective equipment is there to protect the healthcare provider from coming into contact with infectious substances. Okay, so you don't want to put yourself at risk at any time. If there's any risk that you may come in contact with an infectious substance, if you're going to come in contact with somebody's blood or body fluids, you really need to don your personal protective equipment to keep not only yourself safe, but also your patient. Things to remember when using PPE. Remove and discard all PPE before leaving the patient care area. Perform your hand hygiene immediately following the removal of gloves, and PPE should always be changed between patients. You don't want to use the same set of gloves on more than one patient. Injection safety. As an ambulatory care setting, we do run the risk of having more injection safety issues, needle sticks, things of that nature when dealing with our patients. So what we want to do, or things that we have put in place to reduce the risk of needle sticks, we have I believe it was in 2013, we have gone to all retractable devices, retractable syringes and retractable venipuncture supplies to reduce the number of needle sticks that have happened in our county health department. There are some areas, I think especially in immunizations, where we have pre-filled syringes. So in the case where you have a pre-filled syringe, we want to remind you to use extreme caution, but other than those cases, all county health departments should be using retractable syringes and retractable venipuncture supplies. For injection safety, always employ your aseptic technique when preparing and administering your medication. Never reuse a syringe, and always use retractable devices according to the manufacturer instruction. Always dispose of used injection or venipuncture supplies in an approved sharps container that is closable, puncture resistant, and leak proof. Environmental cleaning. Cleaning and disinfection of surfaces in patient care areas should be conducted on a regular basis. Cleaning should involve the removal of all visible soil and contamination utilizing scrubbing action and surfactant or detergent and water. Disinfecting should involve the use of an improved microbial interaction substance that eliminates recognized pathogenic microorganisms. For your environmental cleaning, you need a regular schedule to clean and disinfect surfaces in patient care areas and items that are frequently touched. I notice oftentimes the doorknob is sometimes ignored in the cleaning, but it's one of the most frequently touched items. So there needs to be some type of schedule with your cleaning staff, with those that do the environmental cleaning, to make sure those items are cleaned properly. You want to use only EPA healthcare setting approved disinfectant, and you want to follow all manufacturer instructions for use of approved disinfectants. For medical equipment cleaning, a plan and procedures for cleaning of reusable medical equipment should be established to prevent the transmission of infectious diseases. Critical items such as surgical instruments should be sterilized according to the manufacturer instructions, and non-critical items such as blood pressure cuffs and other reusable point-of-care equipment should be cleaned regularly in accordance with manufacturer instructors. I know with the HemoCube, we have a regular schedule. We're very good with cleaning the HemoCube, but I thought, how often do you clean blood pressure cuffs? But blood pressure cuffs do come in contact with the patient's skin, multiple patients throughout the day. We don't know. There could be some type of substance on there that need to be cleaned. So even blood pressure cuffs need to be considered in your regular maintenance of your medical equipment. For respiratory hygiene and cough etiquette, it should be utilized with patients and other visitors that enter your healthcare facility to prevent the transmission of respiratory infections. You want cover your cough signage. It should be posted in the area visible to patients and visitors, and respiratory care items such as tissue and masks should be made available for individuals with signs or symptoms of respiratory illness. And I do remember back during H1N1, those respiratory stands were purchased, and they still should be in use in all of our county health departments. Those are real good items to use, to have tissue, to have masks, have respiratory and cough etiquette supplies available for your patients and any visitors that may come into your county health department. Dealing with respiratory hygiene and cough etiquette, immediately perform hygiene should hands come in contact with any respiratory secretions. Okay? This is our resource for our guide to infection prevention for outpatient settings, the minimum expectations for safe care. This comes from the CDC, and if you want more information, I encourage you to go read the entire document. What we have provided for you on today is an overview of the standards that are required for ambulatory setting. This is the document that most aligns with county health department. And we just want to reiterate that infection control is very important in our county health departments to keeping our patients safe, to keeping our staff safe. And so we don't want to become overly confident and lax. We want to remain vigilant so that we can care for our patients and our staff on today. Any questions? Okay. Well, we'll give it just a quick moment in case we get a call to come in. If not, we'll go ahead and wrap up on today. Any additional comments, Dr. White?
No, I just again like to thank you and to re-echo the importance of the infection control issues that you've discussed with healthcare health departments. You know, again, as someone who works in the inpatient setting most of the time, that is a very important program that we have in our infection control program. And some of the things that is stressed here, the hand washing, the covering your cough, and how to use and maintain personal protective equipment is so important. I know the situation arises sometimes in the hospital where people will only want to put on personal protective equipment because there is an isolation sign on the door that says contact precautions or so. But when you think about standard precautions in patients who say have a diarrhea or they're incontinent of stool or of urine or something, and you're helping with that patient or so, that patient, I mean, their surrounding is soil, and if you're going to get your hands or your uniform in contact with that, you need to put on a gown and a glove in order to do that, which is practicing standard precautions. And you don't just have to wait until the patient is in contact or you know they have MRSA before you do that. And if you carry that into the outpatient setting and into the health departments or so, that's something that you need to do. Be aware, because those things, you're not only protecting yourself and the environment that you're in, you're protecting your family, because you will take those organisms home too, and before you know it, you're colonizing your home, you're colonizing the bathrooms and all these places, and people can spread infection. C. difficile, I know we have a problem with C. difficile. Patients and people are having recurrent infections, with that. Sometimes we do a lot of things in the hospital to try to prevent that, wearing the gowns, the gloves, and all of that. But then the people go home, or they go to the outpatient setting, or they go to a nursing home, and if they're not aware of those things, they're not cleaning those high-touch areas like bed rails and doorknobs and bathroom equipment, the faucet and things, you can spread those organisms in there. So people take those things at home, and if they don't follow them in the home, they get reinfected and can come back. So this is an area that is, of concern to most infectious disease consultants and people who are in public health, that hand hygiene and infection control practices need to be practiced all the time. And I'll stop here.
No other questions? No incoming calls? If not, we're going to conclude our program on today, and we're going to say thank you for joining us. Have a good day.